Welcome to Kids Matter. I'm Dr. Elisa Minkin. As a pediatrician, mom, and grandma, I understand how challenging it can be to help our kids grow into their best selves. We are so much more powerful together. Here, I will be sharing the knowledge and wisdom of a wide range of people who understand and care deeply about children. I'm hoping for your input as well because kids really do matter. They are our future. Welcome back to the Kids Matter podcast. I'm really honored and really excited to be here today with Dr. Innessa Donskoy. Dr. Donskoy is a pediatric sleep medicine attending physician at Advocate Children's Hospital, specializing in the diagnosis and treatment of sleep disorders in infants, children, and adolescents. She completed her residency training at General Pediatrics at the University of Illinois at Chicago, followed by a fellowship in sleep medicine at Northwestern University and Anne and Robert H. Lurie Children's Hospital of Chicago. After completing her fellowship, she joined Advocate Children's Hospital as a pediatric sleep medicine physician and has advanced into the position of Director of Sleep Education. Wow. She is actively involved in public education and advocacy with contributions to community talks, news publications, and media appearances on outlets such as CBC, NBC, WGN, and Fox News. So this is really, really exciting. And I want to say that this is my second go round with you on my previous podcast, the Jewish Orthodox Women's Medical Association, or JOMA podcast. You came on and we talked more basic about sleep, and I want to link that and not repeat that here, even though this is a different podcast. And what I really want to talk about today is our more challenging sleepers. And I'm really excited to do this because my granddaughter has sleep challenges, and so I'm hoping to learn something here. So thank you so much for joining me. I want to first talk about the possible causes of a poor sleeper in infancy. But before I say that, I just want to say it's not your fault, moms and dads. Okay, we've got this perfect social media stuff, and this is not perfect social media parenting. This is going to be real parenting and not guilt shaming or any of that.
I love that you led with that. I think that we don't hear it enough because sometimes when it comes to sleep or anything that our child is expected to do well, right? We take it as a failure on our parts. And I'm speaking to myself as well when I say this, right? What am I doing wrong? When the reality is the poor sleeper, the bad sleeper, the kid who's never slept well. These are common phrases I'll hear in my office. I'll open with what's happening today, and they'll tell me that never a day in their life has this child slept well.
Uh-huh.
What I often say is, wow, what an amazing young man or woman with what an amazingly powerful brain, right? Our brain is incredible. It is creative. It has memories that it stores short term and long term. It can be imaginative. It can be thoughtful, right? It can be methodic. And that same powerful brain needs to know how to turn off and go to sleep. And the irony, of course, is that the more creative and intellectual and thoughtful and ruminative that brain and child is, the harder that sleep sometimes comes for them. I never like to think of this as like a character trait. I like to think of this as a skill. Sleep is a skill like any other skill. Right. So if I was, let's say, a physical therapist and someone would come and say, my child has never walked and they're a bad walker, right? And they've never walked a day in their life. What am I going to do? I'm going to say, let's come up with a plan to teach them how to walk on their level, meeting them where they're at, understanding what are the underpinnings of this. Yes, how did this begin? What happened in early infancy that made the kind of natural progression of a learning to walk hard? And you can take the word walk away and insert sleep there, and the conversation is exactly the same. right? What kind of unraveled as this child was born and went through infancy and, or, preschoolhood, toddlerhood, childhood, that could have made sleep hard. We think of sleep and insomnia. I'm going to use the word insomnia and sleep problems kind of interchangeably here. There's a definition for insomnia, chronic insomnia. It's difficulty with initiating or maintaining sleep for more than 3 months. But I think colloquially, we just kind of talk about insomnia as difficulty, any difficulty with sleep. So I'll use them interchangeably just so it feels easy. But the truth is that insomnia comes with sort of what we call a 3P pyramid of development, right? The first P is sort of what we call our predisposing factors, right? Everyone is sort of born with a set of genes, a genetic makeup, epigenetic factors that we know, smarter people than I can talk about all the extra things that get added on to the ends of our, telomeres that impact our genetics, right? But we come with we come with a self that is sometimes good at one thing, bad in another, right? Some of us have dark hair, some of us have light hair, and we have a makeup that predisposes us to potentially being better or worse at certain tasks. Math, poetry, sleep. Sleep is one of them. There are some people, and we know that there are identified certain genetic markers that can make sleep hard. And sometimes just reflecting on yourself and your family on both sides can help you see, yeah, are we a little bit of in a spot like that where there runs through our family lines difficulty with sleep? But just because there's predisposing factors doesn't mean there is necessarily going to be a sleep difficulty for this child. Along will come what I call precipitating factors. That's the next P, right? Stuff that happens is essentially what I say, right? Sometimes this can be a major shift in the home, a major shift in the schedule, a major shift in dynamics, or even style. Sometimes when we get excited about a new parenting technique that we want to implement, that's a change, right? Nobody knows it. This is supposed to be, the thing that changes our whole family, but this is a new thing, and it's a stress, if we want to use that word. A stress can come along and precipitate or kind of bring on a little bit of sleep challenge in a child that's predisposed maybe to having sleep already be hard. And by the way, this is where the idea of sleep regressions
I was going to
also,
say, yeah.
right? That's a sleep regression too. Sometimes it's internal. The stresses or new things that come on. And this is happening constantly, especially in that first year of life, but onwards and onwards. We've learned to hold our head up. We've learned to hold our trunk up. We've learned to crawl. We've learned to walk. Forget it. I'm not going to sleep. This is so exciting. I want to do it. I want to practice it. Right. And the other thing to remember about things being exciting, positively exciting, right? Not even just stressful, because we sort of intuitively know that stressful things, negatively stressful things might make sleep hard, but positively stressful things do too. Exciting things. What is excitement in our brain? It's serotonin, it's dopamine, it's norepinephrine, all of these neurotransmitter chemicals in our brain that tell us to be excited. They are also what we call wake stimulating neurotransmitters. And when they're in our brain, they stay in our brain, even though it's 7:30 and it's supposed to be bedtime, right? So
Or
they
10:30. All right, but
or 10:30 if we're lucky, right? So they don't just dissipate, right?
right.
And so that can bring on one of these sleep regressions, which really, if we're just going to break it down, is a lot of residual excitement from learning to do something new, right? That's what a sleep regression is. It should be celebrated. It's hard on us. It's hard on them. But it's good. It means your baby is changing and evolving and learning new things and wanting to reflect on that in a baby way, right? So we have these predisposing factors that maybe make a child more likely to have sleep issues. We have precipitating things that come on, and then the most important P is the perpetuating factors. These are the things that we do as parents that keep sleep issues around. And this is actually where one, the most attention and the most action will be the most fruitful, right? Because we're changing what we're doing. We can't really change those predisposing or precipitating factors, but we can certainly change the perpetuating ones, and understanding what they are really key. Sometimes they're misplaced attempts at fixing the schedule, right? Or fitting sleep in where we can. And at different ages, different perpetuating factors, can arise. For example, in the child that's over 5, right? Putting sleep into the day or giving like naps again would be a perpetuating factor, making sleep at night hard because you're stealing sleep, putting it into the night. Whereas in a younger child, where napping would be completely appropriate, it's not necessarily one.
Even then, though, I think any experienced parent knows there's that dead zone in the day. If they go to sleep, that's it. Even the younger
Yeah.
kids, right?
Yes. 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 And if actually every parent sat and talked about what time that is for their child, they're gonna find that often the times vary amongst each other, right? And so that's why it's also very, very important to know your child's unique schedule. I'm a big fan of sleep logs. Big, big, big. I like data and I like charting it. And I often find that even when things feel completely random, like there's no rhyme or reason to what's going on, sometimes logging for 1 to 2 weeks reveals to you as you're logging it a pattern that you never saw coming. So one thing that I always really like to turn to, not just to buy me some time to think about what I think is going on, but also to have the family just reflect on what's happening day to day. Is I like us to, and the American Academy of Sleep Medicine has my favorite sleep log, one that actually for a kiddo who likes to color and is aware enough, they have them fill them out themselves. For an infant, obviously a parent is going to be doing this, but you color in the boxes where you're sleeping and you stop coloring when they're awake, and then you do it again for every sort of block, and you do it for 2 weeks at a time. And when you visually step back, you see that I I'm gonna hesitate to use this word, but I'll use it anyway. The windows of sleep and awake start to present themselves, meaning there often is much more of a pattern than we realize as to how long a baby can kind of be awake for. It might be different than other babies their age, and that's actually the rule rather than exception, right? How long we can tolerate being awake for, or how high our sleep pressure sort of needs to get before that baby can fall asleep, or needs to fall asleep, is variable, but we start to see the patterns.
Can you explain what you mean by sleep pressure? We talked about it in the other one, but I don't remember.
Yeah, so sleep pressure is just the concept of how sleepy someone needs to be to fall asleep. Chemically, it's very likely known to be adenosine that kind of tracks this. So as that builds up in the brain, we get sleepy enough to fall asleep. And different people have different thresholds of how much sleep pressure they can tolerate. Someone can stay up 24 hours and be fine. Someone can stay up 16. And we know that with little ones, sometimes at birth, they can't tolerate more than 30 to 60 minutes of sleep pressure before they need to take a nap. And what happens on that nap is that they pay off that sleep pressure, and once it's low enough, they wake up and then they do it all again. So, really, in early life, we're almost slaves to that sleep pressure. That's the biggest driver of infant sleep. The circadian rhythm, meaning that internal 24-hour clock, starts to develop and continues to develop as a baby sleeps in, a hopefully stable home with consistent light and dark cycles. But at first, they don't have a time zone. They are essentially just staying awake as long as they can until they fall asleep, staying asleep as long as they can, and then doing it over and over. Which is why making rules is so challenging and unfair, I feel, for early infancy, really like 6 months younger. I might be liberal saying that, but I really hesitate to make firm rules about how long this baby can stay awake for and this baby needs to sleep for at that early age, because they're sort of figuring it out themselves. Their family is figuring them out. And rather than follow some sort of arbitrary, sort of agreed upon rule or time,
12 by
like
12? Like you're dancing around the 12 by 12.
yeah, it's much better to give everybody a little bit of grace. And I find that, if we're not relaxed, we need to fake being relaxed, right? That fake it till you make it phenomenon, because the one thing that the baby is sensing is stress. It is sensing stress, and it needs to know that you're calm and wound down. And if we're nursing, then we're literally passing on that stress, right? And so we need to kind of create this vibe, if you will, in the home of, I'm going to attend to your needs. I'm going to attend to my needs. And we're going to learn ourselves together. We're going to create some boundaries. I think the boundaries are important. I think we also talked about this at the last time we met too, but starting to create that sort of time zone in your home, even upon coming home, is so important, right? So whenever you're used to rising as the parent, right, have that be when lights get bright and sounds go on and activity happens in the home, even during rest periods, right? And then in the evening, when it's your sort of evening for the home, this is when lights get dim, this is when sounds get quiet, and even when we're interacting, right? When this baby's woken up for its whatever number diaper change or feed throughout the night in this home, right? We're still quiet and things are still dim, so that we're reinforcing the light dark cycle that's actually going to build the internal circadian rhythm.
I love that. That's excellent. So what we were talking about was basically giving sleep cues, which is good. But okay. I want to go back to the perpetuating factors, because I
Yeah.
feel like we really need to go into that more, because as a pediatrician, I do see this. I do see that parents are unintentionally doing some things that are counterproductive. And I think since that's something we do have potential control over, I want to talk about that more, please.
I mean, we really the perpetuating factors, again, they change based on age, but we never want to make a decision for right now that we're not okay with sticking with that decision long term. So this is the stuff we do to get baby to fall asleep just this one time, and then it becomes a habit. So the rocking, the holding, you know, we won't get into like the safety part of it, but obviously the bed sharing is a no for multiple reasons. But just one of them is then that is something that the baby will become accustomed to, and no, learn to enter sleep in this way, right? When babies are falling asleep, when any human falls asleep, they are entering sleep cycles. They're entering shallow sleep, right? Followed by deep sleep, dream sleep. In infancy, it's largely going between just deep and dream, but we are entering sleep for a sleep cycle. In infancy, they're usually between 30 to 90 minutes long. They're getting longer and longer, closer to 90 minutes by 1 year of life. So they can be short, which is again why it's hard to make rules. But once they finish that sleep cycle, they will need to fall asleep again, into the next sleep cycle. So if you're not still nursing, rocking, holding, patting their tush, whatever thing you were doing, if you're not doing it anymore, they will find you. They will alert you with their cry, their sweet little cry, and they will let you know that you have left their entrance ticket to sleep cycles. You've left. You have to come back. They're unable to enter sleep a different way. If you are teaching them over and over and over, this is how you start a sleep cycle by being rocked. They will need it every single time they enter sleep cycles again.
That's really an important point, and we kind of skipped right over a couple of things. First of all, I want to say that the 12 by 12, just to clarify, is a program to teach children to sleep 12 hours by 12 weeks old. And actually, for some people, it works. Okay. So we're not going against that, but any program that you think is a one size fits all, it's not true because every kid is different. So I just want to make that point. I don't want to be disrespectful to that program across the board, but back to that, not perfect parenting, there is no perfect solution for everyone. Okay.
Yes, and I don't want to interrupt you, but yes, I
Yes.
completely agree. This isn't meant to poo-poo any method,
Right.
because the truth is that there are going to be things that you find that just click and resonate with you as a parent, or really work for this particular kid, and that is amazing. And congratulations that you found the right sort of combo, right, for you and this mother or parent child diet, right? But yes, I completely agree with you. It doesn't necessarily then mean that it will work for another child, even another one of your children. It's so hard for parents sometimes to come in with their, second or third or beyond child and say, I don't get it. This worked for everybody else. Why isn't it working for this kid? Right? And it's because they're a unique human. And when you grow
Exactly.
up and they're adults, you're never gonna believe that you compared this one with this.
Right.
Gosh, this was like on one street. This one's like learning full time. They're so different. So why do we expect them to be so identical? Right?
We
When
want
it
them to
comes to
sleep. Okay. I want to go back over a couple more things. Speaking of sleep, okay. In terms of co-sleeping or bed sharing, we are just going to put that aside. That is just outside the scope. We are going to
Perfect.
emphasize safe sleep practice, but also acknowledge that some people choose to do this. We cannot fit that into today, but I just want to put that out there. Now, some people, I think more people are choosing to bring the babies in bed with them out of desperation, okay, as opposed to as a planned choice. And that, to me, is the biggest problem of all, because they are the least likely to take practices to make it safer, right?
Yeah.
And so that's a concern. But they also may not realize that they didn't start as they meant to go on, that they took something
Yeah.
on, and then they're wondering why the kid's still in their bed, however many years later. But the issue with that is the real, to me, the real nitty-gritty issue is whether you agree that a child needs to learn to self-soothe, because there is an ideology, right? This attachment parenting kind of style where you believe that it is your job to soothe your child. And I'm just putting it out there. My concern as a pediatrician is that I'm concerned for parents being asked to parent 24/7, 365, this intensive parenting style. And I think that what often happens is nobody sleeps well. That's my take here. I'm not trying to be disrespectful to anything. I don't know if people really understand what happens over time in this particular situation. You can talk about it to say
Yeah,
that.
I mean, I'm by no means even a beginner expert in attachment parenting, but it's interesting to hear that like dichotomy of, is it the child's responsibility to self-soothe, or is it the parent's responsibility to soothe them? To be honest with you, I think it's a parent's responsibility to help a child recognize and foster the skills to self-soothe. And I think that looks different at different developmental stages, right? I
Different
think that
kids.
Yes, and different kids, but even the same
Yes.
kid, right? Even the same kid at different times of their development, right, are going to be able to access recognizing their emotions, naming them, choosing the way to respond, right? This is such a mature thing we're asking them to do. Adults can't do that sometimes. But I think parents can. What I often ask the parents I'm seeing in clinic to do is I'll often ask them to reflect on their child's day, really, and what helps them calm in a tantrum, what helps them kind of calm in the middle of an anxiety, like a feeling anxious, separating. What tools or things or techniques help them with the challenges of the day? Because often accessing those very particular tricks, tools, sounds, toys, whatever it is, can be so helpful to take into the night. And this is where sleep care becomes so unique. The things that I've recommended like kids take hard trucks or into bed with them, right? I've recommended crazy things that just seem to help in the day into the night, right? And I think also we're talking about largely neurotypical kids mostly.
To move on to the
But then
neurodivergent.
yes, but when you talk about kiddos who are a little bit neurodivergent or neuroatypical, it opens the door even more to creative and unique techniques, right? There is so much discussion about screens and the light, but also like the content that can be alerting for kids, even though screens are used throughout the day. Um, but take a kiddo who that is their means of communication and self-soothing, who's neurodivergent, and I'm asking them to take their devices into bed with them because it's helping them wind
Really?
down in their unique way. Yeah, if that's what you need in their unique case. This is again, there's no cookie cutters
Oh,
here. But
wow.
but if they're nonverbal, this is their only way to get their needs communicated and met. And you are essentially duct taping, their mouth by removing it at night. That can be tremendously anxiety provoking. Who's going to relax and trust enough to close their eyes and fall asleep? Right? So there's a lot to be said about taking things really, really case by case.
Wow. Do you mean kids who have an augmentative communication device, or are you talking about kids who are just
Yes.
watching screens? Because when
So
a lot of these kids just like to watch videos, it'll never end. How do they fall asleep?
right. So I'm largely talking about their communication devices, but I'll be honest, it really depends. It depends on what that device is doing for them at that moment. This might be our bridge to, the next steps we're going to take in sort of sleep care and hygiene. But I think the point here is that it's not one size fits all.
I love
No,
that.
I'm by no means endorsing watching screens before bed at
I
large.
but the point that you're making is so incredibly important that each child is different, number one. And number two, neurodivergent kids tend to have more sleep problems, more severe sleep problems, right? And so the answer is going to be different. And there they are going to be going on social media and seeing, oh, my kid fell asleep with the 12 by 12, whatever. And they're like, why is my kid like, 13 years old and not sleep? I'm making this up. But, I mean, like,
That's
these are really huge problems. What other nuggets do you have for neurodivergent families?
so again, I think finding patterns is very, very important. You know, we can have when it comes to difficulty with falling and staying asleep, sometimes it's important to distinguish this from an internal kind of time zone or circadian rhythm disorder. So sometimes our child's sleep can feel unpredictable, but when we take a step back and we kind of log and track it, we realize it's just set later, perhaps than we would like it, or earlier, or it's even irregular, meaning they might be taking their sleep and splitting it into two or three big pockets of time. I see this a lot with the neurodivergent kiddos where they might have both a delayed sleep wake phase, meaning they're falling and staying asleep significantly later than their age matched counterparts, but they're also not sleeping enough on weekdays, right? Because they're trying to flip flop between two time zones. And then there's putting this gigantic nap into their day. And then it's essentially taking from their night. So we're ending up with just broken sleep across the board. So tracking it, I think, is very important. Understanding a pattern, enlist the help. Enlist the help of a sleep coach or doctor or sleep psychologist if you're having a hard time finding the pattern yourself, but also be very ready to notice that the amount of hours your child needs may not fit their age bracket, meaning those, agreed upon National Sleep Foundation, Academy of Sleep Medicine Foundation. There's recommended amount of hours of sleep per age. I've often found that those are much lower, especially with kiddos on the autism spectrum. I don't know if they need less sleep or they're getting less sleep, but often I find that when we sort of decide with the family that this is the amount of sleep we're going to aim for, and we're much more reasonable with our expectations of time in and out of bed, suddenly falling and staying asleep become easier. And that, in and of itself, is sometimes more beneficial than reaching a certain sort of predetermined amount of hours,
I see. I
meaning
see.
unbroken sleep, right? Consolidated sleep in a dependable time window. That is even more refreshing than meeting a certain amount of hours, down to a limit, of course. But this is where it comes down to every kid is so unique.
Right. So what you're saying is some kids may not fit the molds and you're fighting against what they need, actually.
Yep, yep. And so then we're putting them in bed too early, and maybe we're using sleep medicine, medication, to get them to sleep. And we pat ourselves on the back because they're asleep, but then they're up, right? They're up in the middle of the night. And were we to have stepped back and say, well, maybe if we sort of compress sleep, right? Or restrict the time in bed to a smaller window, then maybe falling and staying asleep can now come more easily even without medication, maybe. And now we've got it like a window we can depend on.
I want to talk about medication, but before you mention sleep coaches, how do you know who to go to? And this is where we're talking about a family, it's really distressing, okay? The child's sleep issues, for whatever reason, are really distressing. They don't know what to do. Who do they go to first? How do they choose between a sleep coach and a sleep doctor like you? And did you mention a third professional?
Sleep psychologists.
Sleep
Yes.
psychologist. So sleep doctor, sleep physician, which you are, sleep psychologist, and a sleep coach. How do you know? Who do you get to first?
And then there's sleep consultants,
Right.
and
Is that
health
different from a sleep coach? Is that just a
educators. Yes, no, they're all different. So the truth is that there's a very wide variety of different people talking about sleep. Some of them are immensely evidence-based and thoughtful, and very like will tailor the care to each child. Others are very cookie cutter. This is the package. You pay this amount of money for the package. You watch the videos, and that's the sleep care. So, the one thing that I'll say is that just be careful. Be careful where you're turning for care, and also how much money you're spending for care. It's so heartbreaking when a family will spend a tremendous amount of money and sort of get advice that's not right for them. Might be right and amazing for somebody else, just not right for them. So I would honestly, and my answer is obviously biased because I am coming from the medical community, so I will totally admit that before I say what I say next. But I would start talking with your pediatrician. Often, a pediatrician will know community resources, and if you happen to be in an area of the country with a pediatric sleep medicine program, they can refer you to a pediatric sleep medicine doctor like myself that's in your insurance network, and your insurance can pay for it like any other doctor visit, which will hopefully be the least amount of money you have to pay. Depending on where you are in the country, the sleep medicine department may also be attached to a sleep psychologist department. And these are even better than sleep doctors. Honestly, I have so many amazing colleagues that are sleep psychologists in Chicago, Boston, Philadelphia. There's a lot of them out there. Many of them do research, but a lot of them do clinical care as well. And they are phenomenal because not only do they have evidence based sleep medicine background, but they also have a psychology background. They've had to go through that training and they can access tools and techniques that medical doctors never learn. So, really, one of my favorite things to do in complex cases is to partner and have me taking care of the medical or maybe medication side of it and having a sleep psychologist co-manage with cognitive behavioral therapy for insomnia or other behavioral techniques that can help again in a case by case basis. There are amazing sleep coaching consultants out there. I actually, I'm not plugging or promoting anyone, but I actually teach and do some lectures for the Sleep Coach Academy run by Jerome Lazarus. He's amazing. And what you can tell about a sleep coach is where they come from and what sort of continuing medical education or whatever the equivalent is that they're getting, right? If they are actively learning and increasing their knowledge base, then hopefully you'll be in good hands. And the absolute best thing to hear someone say, really, when you hear someone say this, you should think highly of them is if they admit to you that this is beyond my ability and I'm going to have you someone else. If someone ever says that to you, that's probably the smartest person you know,
Because
right?
they know their
Because
limits, because they know their
they
limits.
know what they know and they know their limits. So I never want anyone to feel if some ever responds back to them with that, it means that they care so much about you and your child that they want to get you to the right level of care.
I love that. And I want you to talk to me as a pediatrician and other pediatricians listening as to when that family comes to us, some resources and some questions we should ask. What pediatricians should know, what parents should know that should be ruled out, right? Because we don't want to miss medical conditions. We're not going to go into great detail, but just maybe some basics.
Okay. Yes, absolutely. So my little 5 second speech on sleep basics is that sleep should be still and silent. So if your baby is tossing and turning and moving and kicking and rolling and wiggling and all about the bed, not still, that might be something to bring up to your pediatrician. Sometimes incredibly simple things lead to restlessness in sleep, iron deficiency being a big one. So don't go self treating that. Talk to your pediatrician about if your baby is very restless in sleep. And if your pediatrician says, I don't know what to do about that, ask for a sleep medicine referral. And not only should sleep be still, but it should be silent. So you should be needing to come in and check and listen and feel if your baby, is having their chest and belly hopefully rise up and down quietly. If your baby is snoring, grunting, making any noises like this repeatedly over and over in sleep, if they're mouth breathing, if they're gasping, if they're taking big breaths like that or grinding their teeth once they have teeth, I guess that's for a little bit of an older child, that is also 100% something to bring up to the pediatrician. A baby who's moving like that excessively or breathing uncomfortably should be evaluated for other sleep disorders like sleep apnea or periodic limb movements in sleep. And the most important thing to remember about a baby like that is that we don't want to be giving anything for sleep medication wise until we know that it is safe for that baby to stay asleep. Meaning sometimes kids, babies with sleep apnea, with limb movement disorder, they're waking up over and over to breathe, to move, right? And so that is not a child that we want to just see if, commonly parents will come in about having already tried things like Benadryl or melatonin. a baby like that, we want to make sure is safe to stay asleep first.
Literally, don't try this at home,
Yes.
right? Do you want to speak a little bit about Benadryl and sleep? Because parents do this. And then melatonin. And then I'd like just a little bit about what else is out there from your doctor, your specialist doctor, right? I don't even know this is usually prescribed by pediatricians.
Yeah, well, I mean, the truth is that Benadryl and melatonin are available over the counter in the US. Across the outside of the US, melatonin actually needs a prescription, but these are commonly available over the counter, I say medications loosely because they're not regulated like medications in the US either. They're regulated more like a food. And so one of the most disconcerting things about melatonin is that the amount of milligrams it says on the bottle, the liquid, the gummy may not be how much is in that bottle, or even gummy to gummy, pill to pill in that bottle, which is terrifying. I think in 2017, there was a study that came out that did some purchasing of over the counter melatonin formulations and batch testing them. And there was a very alarming mismatch at how many milligrams of melatonin were truly in the formulations based on the way that they were sort of labeled. So that's the one thing to remember is that it's not regulated like a medication, but it is a medication. So they're different. Benadryl is an antihistamine. Histamine is a wake promoting neurotransmitter in the brain. And so antihistamine will block that, block those wake signals, and give a sleepy, sedating effect. It can also suppress just like how well a baby responds to having trouble breathing. So I would not recommend giving an antihistamine. Again, if you're seeing any of those signs of sleep disordered breathing, but know that it's going to just mask their wake signals, and this baby might fall asleep. Interestingly, antihistamines will make things like restless legs worse. So there are some paradoxical effects you can sometimes see, meaning like the opposite. Instead of falling asleep, like a little bit of even more agitation and antsiness. That's sometimes a clue that there might be a restless component there, but it's not going to be a lasting effect. Once that Benadryl wears away, that baby will wake up, but they will be used to that effect. They will be used to that dose. And they may come to need that sedating effect for sleep. Not to mention the ethical discussion of sort of kind of blindly treating a sleep disorder, right? You're sort of deciding your baby has insomnia and that they have an insomnia that's not amenable to behavioral techniques, and you're sort of self-treating with an antihistamine medication. It might also be just causing problems later on where we're going to have to wean away or get used to the sleepy cues that come naturally, right? The sleepiness that's going to come from an antihistamine is going to be far more potent and overwhelming than the natural sleepiness that comes the hours before we're ready to fall asleep. And so, if we're used to that effect and that being what sleepiness feels like, it's going to be very hard for us to recognize our own internal cues. So that's Benadryl. Melatonin, I mean, you can say a similar sort of issue on sort of self-diagnosing and treating. You can also make a similar argument that the melatonin is going to be sedating. It's going to have a sedating effect. And so that will be, expect sleepiness to feel like, right? And it's not going to match what their internal sleepy cues feel like, which means they'll have to, at some point anyway, learn again or learn for the first time what naturally falling asleep feels like. But the other problem with melatonin is that it can actually be a very good tool for the right sort of sleep disorder. So, this is where it becomes a little bit tricky. Melatonin has different receptors in our brain that it can act on. Some of those receptors sort of control our internal circadian rhythm, our internal time zone, and some of those are just like sleepy, sedating cues. So, when it comes to jet lag, traveling, needing to realign your circadian rhythm, melatonin is actually an indicated medication, even in pediatrics, for resetting the internal clock. So it does have a very real, sort of medically sound role there. But the way it's often used in kind of everyday culture is I feel like it's used much more for insomnia, like we said at the beginning, just difficulty with falling and staying asleep. And then it's used sort of very differently rather than intentionally to bring an internal clock forward or backward. It's just sort of given right before bed to bring on that sleepiness and put someone to sleep. It's actually not the best choice for insomnia management from a pharmacologic standpoint. There are much more effective medications, even for pediatric insomnia. And not only are those medications much more effective, but we know what side effects to look out for. So, melatonin hasn't really been studied given long term in neurotypical children. And so we actually are a little bit blinded to what are the long term effects of being on this medication for sleep. We don't know. And that makes it very, very hard to give a family appropriate guidance on, well, look out for this. And if you see this, give me a call and we'll stop the medication. We don't know any of that for melatonin. And so it's kind of like a guessing game. So not only is it not really effective for insomnia all the time, but we also don't know what to look for in the long run.
Push back a little bit for the neurodivergent kids. I do think we
Yes.
do have evidence there,
Yes, yes. So for the neurodivergent kids, absolutely. Yes. So, yes, for the neurotypical, we don't. But now for ADHD and especially autism, there is great data for actually a 2-year cohort that was followed on extended release melatonin that found they did nicely for sleep onset and maintenance. Yeah, in the neurodivergent population, we do have more data to support it. It's still not phenomenal, but a 2-year follow-out was very exciting to see a few years ago. So I think there will be hopefully more and more coming from those groups.
I want to say two more things. Yes, it is under the FDA not FDA approved, so you don't necessarily know how pure, how much milligrams is in it. But I do believe that you can find out more reliable brands that you have a much
Yes,
better chance.
yes. Any
I'm not asking you to give any. We're not
USP.
giving any
Yes, yes.
medical advice here at all. This is not for medical specific advice, but that's another reason to go to, your pediatrician or have a referral out so that you get an appropriate, not just any random melatonin,
Yes,
if
yes.
you're
And
going to
then
use it.
yes, and I think the USP verified check on bottles, my understanding, and this is what we kind of tell patients now, is that that is at least a company that's having somebody third party batch test
Third
their
party testing.
dosage.
Yeah, so there are some indications, and then your pediatrician may know some good brands. Again, we're not giving those any recommendations here.
Got it.
So that was another thing. And the other thing I wanted to point out is that melatonin, as you mentioned, helps you fall asleep, but not stay asleep. So I wanted to
Correct.
clarify when you mentioned extended release, why that was so important.
Yes, yes, yes. So, yes, it's a sedating medication, which means that once it's gone, and it's very likely still the middle of the night. So, it is not going to help a child with staying asleep. There are extended release melatonin formulations out there, but again, if this is something that you're sitting thinking, I wonder if my child needs that, that's a conversation I recommend you just have with someone else who can kind of guide you on, perhaps identifying really the sleep disorder or disorders that are going on and really the right next step of treatment.
I promise I'll let you go. So I'm gonna let you go, but I'm so grateful for this opportunity for people to understand, the range of professionals out there and just emphasize again, you're the parent, you have your mother instinct, your father instinct. If your child is not getting the help they need, go to the next level. I think that's really important. And look what sleep physicians can do. This is great. You're amazing.
Yeah, and if there's anything else I can also add is that comparison is like the root of all issue, right? I'll often hear feedback that like, well, my neighbor's child goes to bed at this time, or the other kids in my kid's class go to bed at that time. And the truth is that if you are feeling like your child is having difficulty falling and staying asleep on their schedule and in your kind of home and world, that's one thing. But if things are going great and your kiddo's thriving, but their sleep schedule is just different than someone else's, that's okay.
You didn't read the book. That's okay.
Yeah.
So thank you so much for doing this with me.
Well, it was my pleasure. My pleasure. I hope I'll get to see your face soon.
I know. Sorry for the glitches, everybody.
Thank you for listening to Kids Matter. Raising healthy, happy children takes a village, and I'm grateful you're part of ours. If today's conversation resonated with you, please share this episode with another parent, grandparent, teacher, or anyone who cares about kids. Together, we can build the supportive community our children deserve. I'd love to hear from you. Share your thoughts, questions, or suggestions for future topics at kidsmatterpodcast@gmail.com with no exclamation point. Your voice truly matters. Until next time, keep advocating for the children in your life because kids really do matter. They are our future. I'm Dr. Elisa Minkin, and this has been Kids Matter. Please note that while I am a pediatrician, I am not your child's pediatrician. This podcast is for informational purposes only and does not constitute medical advice. For any medical concerns or decisions, please reach out to your child's healthcare professional.